Bronchiectasis refers to the irreversible airway dilatation that involves the lung in either focal or diffuse manner, and it can be classically categorized as cylindrical or tubular, which is the most common form, varicose or cystic. Now, moving into the etiology, etiology of the bronchiectasis can be congenital cause like cystic fibrosis, ciliary dysfunction syndromes, or it could be acquired, that can be acquired in the children because of the severe infection in the infancy, especially like whooping cough, measles, or it could be due to primary tuberculosis, or after it could be non-infectious cause like the inhaled foreign body, or it even patient in adult can also develop the bronchiectasis after a respiratory pneumonia or the pulmonary tuberculosis or as allergic bronchopulmonary aspergillosis complicating asthma. And it can be classified according to the involvement of the lung, that can be focal or the diffuse. And focal bronchiectasis is usually seen in cases of obstruction by the aspiration of the foreign body or by the tumor mass. And in diffuse involvement of the lung can be seen in bronchiectasis cases if the patient has infection, which can be bacterial, tubercular, or it could be non-tuberculous mycobacterium like Mycobacterium avium complex, or patient who has got immunodeficiency due to hypogammaglobulinemia or HIV infection or bronchiolitis obliteration, or in patient who has undergone the transplantation, or the patient who has got history of the recurrent aspiration, or the patient who has got systemic illness like the rheumatoid arthritis, Sjogren syndrome, or inflammatory bowel disease. With all these cases, there will be the diffuse involvement of the lung in cases of bronchiectasis. However, by seeing the particular area of the involvement of the lung, you can also find out the etiology. It's like in cases of cystic fibrosis and in cases of the post-radiation fibrosis, the bronchiectasis is usually seen in the upper lung felt. And in cases of the infection due to non-tubercular mycobacterium, that is due to the Mycobacterium avium complex, there will be the preferentially the affected lung will be the mid lungs. And if there is the patient has bronchiectasis in the lower lung field, you should always think if the patient has chronic recurrent aspiration, which may be due to esophageal motility disorders, like in case of scleroderma, or in cases of the interstitial fibrotic lung disease, or patient who has got immunodeficiency. Now, moving on to the pathogenesis and pathology of the bronchiectasis. Usually, as I've already told you, it doesn't occur in the case of healthy individual. It's usually occurred when there is poor mucociliary clearance in the lungs, or the patient is immunocompromised and there is high susceptibility to infection. And both high susceptibility to infection and the poor mucociliary clearance, like in case of cystic fibrosis or ciliary dysfunction, there will all result in the microbial colonization at the bronchial tree. And the most common organism that's usually found is Pseudomonas aeruginosa, because it has got a particular property to colonize the damaged airway and evading the host defense mechanisms. And when there is the colonization of the organism, then there leads to the continued chronic inflammation, which causes damage to the airway wall, and there will be continued impairment of the secretions and microbial clearance that all lead to the deposition of all the microorganism, and which leads to all the propagation of the infection and the inflammatory cycle. And there will be the infiltration of the inflammatory cells, and which leads to the release of the various things like protease and other mediators such as reactive oxygen species and pro-inflammatory cytokines. However, they are released so that there will be the destruction of microorganism, but they are not only destroy the microorganism, they also damage the larger ear walls, which even the smaller airways are also destroyed, and this all leads to the dilatation of the airway with loss of elastin and smooth muscle and cartilage, and this leads to the irreversible dilatation of the airways, usually larger airways. And Now moving on to the clinical features, the patient usually presents with the pulmonary symptoms like cough, sputum production, which can be copious, and it could be of positional variation. The patient may present with pleuritic chest pain, or the patient even present with hemoptysis, halitosis, and and when you examine the patient, you could find the patient may have clapping, and on physical examination, you will often find crackles and wheeze in the lung fells. And when you do the pulmonary function test, you will find out there is mild to moderate airflow obstruction. Now moving on to the investigation. Non-invasive investigation includes the sputum for the stain, gram stain and culture. And as I've already told you, most of the cases you will find out there will be Pseudomonas aeruginosa and other organisms like Staphylococcus aureus. Even you can find out there can be fungi such as Aspergillus and other various mycobacterium. And the imaging modality includes chest X-ray. And in cases of the starting of the disease, you may find out the chest X-ray can be normal. Chest X-ray is abnormal only in cases of the advanced diseases. And in such cases, you can find out the thickened airway walls, or there will be cystic bronchiectasis spacious and associated area of pneumonic consolidation or collapse can also be visible. And if you suspect the patient has got the bronchiectasis due to the ciliary dysfunction, then you can also do a test in which you can put a small pellet of chasterine in the anterior chamber of the nose, and you could find out, you could see that if that reaches to the pharynx at pharynx and the point, the patient can test it in the given particular time. And chest CT is the imaging modality of the choice. And what do you see in the computed tomography of the chest is that you could see the airway dilatation, which is also known as Dram-Jack or signet ring sign. You could see that the bronchial wall has got thickened and it is dilated. And even due to the inspissated secretion, you can find out there is train board-like pattern. Now moving on to the treatment. And the treatment is directed towards the three principles, that is control of active infection. That is, if there is any presence of active infection, you need to control that. And for the long term, you should think of improvement in the secretion, bronchial secretion. And the third thing is bronchial hygiene. And the most common principle of the treatment include to decrease the microbial load within the airway and minimize the risk of repeated infection. And now moving on to the treatment, that is treatment with antibiotic. Usually the patient doesn't always need antibiotics. However, if there is presence of acute exacerbation, which is usually characterized by the changes in the nature of sputum production, that is either increase in volume or the purulence of the sputum production, then we have to give the patient the antibiotics. And the most commonly isolated organism is Haemophilus influenza and Pseudomonas aeruginosa, and so we should give the antibiotic that covers this organism. And usually antibiotics should be given to the minimum of the 7 to 10 days. And the usually commonly used antibiotic is the fluoroquinolones like ciprofloxacin and or anti-pseudomonal beta-lactams. And for the tuberculosis causing mycobacterium, then we have to give a macrolide combined with rifampin and ethambutol. Now moving into the bronchial hygiene, which is very important in cases of the bronchiectasis, so that that will enhance secretions clearance, so that which leads to less colonization of the mycobacterium and the less exacerbation in cases of the bronchiectasis. And the bronchial hygiene includes hydration and mucolytic administration, even aerosolization of bronchodilators and hyperosmolar agent like hypertonic saline. And even the thing that we can do is we can go for the chest physiotherapy, and it can be done by the typical traditional method, that is by the hand clapping on the chest or by using a device such as oscillatory positive expiratory pressure flutter valve or a high frequency chest wall oscillation vest. Or even you can, in cases patient who has got cystic fibrosis, you can use the mucolytic tourniquets. And for the use of anti-inflammatory therapy, glucocorticoids can be maybe important in treatment of bronchiectasis in some certain causes like ABPA or some non-infectious bronchiectasis due to underlying condition, especially that in which there is autoimmune condition like rheumatoid arthritis or Sjogren's syndromes. And in case of ABPA, the patient may also benefit from the use of antifungal agent like itraconazole. Now moving to the other modality of the treatment, that is surgery. In the patient who has got focal bronchiectasis, we can do the excision of the bronchiectatic area. And for the patient who has a refractory case, that means there is diffuse bronchiectasis, you started the patient on the oral medication and you all maintain the bronchial hygiene, but again the patient has got refractory acute exacerbation, then you can go for the resection of the particular destroyed areas of the lung that are acting as the reservoir of the infection. Now moving on to the complication of the bronchiectasis. The most common complication is the recurrent infection, which leads to repeated course of antibiotics and which can lead to microbial resistance to antibiotics. And also there is, due to the repeated infection and repeated colonization of the organism and the accumulation of secretions, this all leads to injury to the superficial mucosal fascias with bleeding, and in severe cases it could be a life-threatening hemoptysis. So in such cases, the patient may need the immediate treatment. Patient may require immediate intervention to stabilize, and the other thing that you should do is you should quickly identify the source of bleeding, and you should protect the non-bleeding lung. And in cases of the severe cases, even you can go for bronchial arterial embolization or some cases surgery. Since the bronchiectasis is a chronic condition and the patient has to live with it is better to prevent the disease. And how to prevent the disease? So to prevent the disease, if it's usually start from the childhood, and if the patient has got any infection in the childhood, like measles or whooping cough or primary tuberculosis, you should ensure that the patient get the proper and complete treatment of this condition. And in patient who has got immunodeficiency state, you have to administer the gamma globulin. And in patient who has got risks for repeated respiratory tract infections, you should vaccinate such patients with influenza and pneumococcal vaccines. And usually there is presence of recurrence of infection cases of bronchiectasis, and usually a recurrence is there can be more than three or more than 3 episodes per year. Then you can also, there are various method utilized so that there will be less recurrence of the infection, infective exacerbation cases of bronchiectasis. And one is the use of the antibiotics for the prolonged time. We have to use antibiotics such that there will be less antibiotic resistance, and this can be done by using the using the oral antibiotics like ciprofloxacin once daily for the first 1 to 2 weeks per month, or you can even use the antibiotics in the rotation schedules, or you can even use the administration of macrolide antibiotic like azithromycin daily or 3 times per week, or even you can go for to reduce the systemic side effect and systemic resistance. You can use the inhaled aerosolized antibiotics like tobramycin inhalation solution in a selective patient, and all in the rotating schedule, so that there will be less development of the antibiotic resistance. This is all for today. Thank you.